Welcome everyone to the Menrva Lounge, joined by Dr. Betty Murray, my co-founder here at Menrva, and excited to dig into some of the physical aspects of perimenopause and menopause. So to begin, Dr. Betty, maybe just share the hormonal changes that happen during perimenopause and then menopause, and then I'll dig into those physical changes that occur.
Yeah, so there's a lot of changes that happen. We have to remember that perimenopause and menopause are the changes in your sex hormones, estrogen, progesterone, and testosterone. And all of those hormones that first fluctuate wildly and then basically flatline by the time you're in menopause. Now, testosterone doesn't fluctuate as wildly. It actually has this sort of slow decline from our 20s and 30s. However, when progesterone and estrogen change, and then you get the reduction of testosterone, what happens is you get a huge amount of physical things that we see. So that's things like all of a sudden we notice our skin is sagging a little bit. We might have wrinkles. We might have our hair graying more rapidly. Hair changes, which I think we're going to talk a little bit about today. And it's because these hormones have strong influences on the physical body. And so in the beginning, it might be small diffuse things like a little bit of hair loss and stress-related hair loss, but particularly by the time we get in menopause, a significant portion of women will have extraordinary changes to their body composition.
Okay, got it. And so, in terms of like fluctuating estrogen and progesterone levels that affect us, like what would you say the biggest aspects in our physical body do they make?
Yeah, so when we look at progesterone first, because that's the one that declines first. So for most women, that starts in our 40s. For some women, if you're like me, it will start in your late 30s. So we start to notice some of the other things like sleep problems, where you have insomnia, you can't get to sleep. You might wake up in the middle of the night and not be able to get back to sleep. We might notice more anxiety, more frustration. But what's really, really interesting too is we can see changes in our hair at that time too. And anybody that's ever been pregnant, like during that last trimester, all the women experience usually like their hair grows wildly during pregnancy. And then you give birth. And then all of a sudden you get this sort of shedding event. So it's not uncommon to see some shedding for women during this time period. The other thing that we see too, and this doesn't really get enough information out there, but the slow decline in testosterone can also cause hair loss, because most women think of testosterone as a hair loss if it's too high, but it can also cause hair loss if it's very, very low. And a lot of women, because of stress and other things, are experiencing changes in progesterone and also excess cortisol and a reduction in progesterone that starts to affect the hair, skin, nails, everything.
And is the hair thinning that accelerates, is that going to be permanent or is it something that someone can just expect temporarily?
It depends. So if we think about stress-related hair loss, so when we're under significant periods of stress, even sometimes things like COVID caused hair loss, we'll get diffuse hair loss. So what that means is it's sort of spread all over the scalp and it's not in a particular patch or area. Often that can occur, and when the problem goes away, so when, the stress level comes back down, life normalizes, the hair will go back and often is not really altered. Same thing with progesterone changes. You'll see the hair grow back. It's just that change in progesterone level that often sort of causes the shedding. What's interesting, though, is if a woman has risk for female pattern baldness and androgen-related hair loss, which is a significant portion of women. And what does that mean? That means that when you go through menopause and you have the loss of estrogen and the reduction of progesterone, even if your testosterone and DHEA, which is one of the other androgen hormones, and another hormone called DHT, even if they're not significantly high, they are in most menopausal women relative to the amount of estrogen. So what does that mean? You could have low testosterone and low DHEA and experience hair loss and also experience low testosterone symptoms. And so the challenge is that most people don't realize that that's really going on at all. And so And so as women, we end up with these sort of symptoms, and we're like, wait a minute, I don't have any libido, my testosterone's low, but I may also be experiencing male pattern baldness. So what does that look like? It's often loss of hair along the kind of widow's peak area, so up along the sides of your hair, thinning at the crown. And what's even more insidious is you'll start to see things like the hair becomes thinner and finer. So our hair, when it grows, we go through a growth phase, and then it goes through a sort of dormancy phase that falls out, and then it goes through a dormancy phase. When we have excess androgens active in the skin surface of our scalp, but even with low testosterone, but it's active here, you get the hair will fall out like it normally does. We lose about 100 hairs a day on average. But it'll fall out, but the dormancy phase stays dormant longer. So it takes longer for it to grow back. And it grows back thinner and finer and often more wiry. So women will say, oh my gosh, I'm going through perimenopause and my hair is thinning, and also the texture changes. Like, I have very, very thin, fine hair. I always say to everybody that my hair never grew up. I have hair like a baby, right? Like that little like dewy baby hair that you can't even put in a orthodontics, rubber band. My hair has always been like that. And when I started going through perimenopause and menopause, that was also during menopause in particular, was during COVID. So I kind of got hit with both back to back, and I lost a significant portion of my hair. But when it grew back, it was almost like cotton candy. It was so thin and so fine and kind of fluffy, like you couldn't tame it. And a lot of it was there was active DHT in my hair follicle, despite my DHT hormone levels on a blood lab looking normal. And so I think a lot of women are experiencing hormone related hair loss or hair changes, and they go to their doctor. And even if they do get tested, they may be told that they're fine, and that's not true.
Yeah, so what would a next best step be for somebody that's experiencing some hair loss?
Yeah, so the first round would be to look at things like getting a hormone panel. So if you're still cycling, you want to look at your hormone panel in the second half of your cycle, the time that we often associate with kind of PMS, which is if you're to take the day that you start your period. So let's say you start today, you're going to count about 19 to about 21, 22 days from there. And you want to get your blood work ideally in that range. If your cycle is about 28-ish to 30 days. If it's significantly longer, you might want to spread it out a little bit. If it's significantly shorter, scoot it back a little bit. And the reason why is that's going to get your hormones at their peak during the luteal phase of your cycle, which is when progesterone and estrogen is very high. Testosterone is pretty consistent in women. We don't see this fluctuation at any time in our cycle. You want to test for estrogen, progesterone, testosterone, free and total, DHEA sulfate, called DHEAS, and DHT. DHT is dihydrotestosterone. It's 7 times stronger than testosterone, and it's what causes hair loss. Now, when you get those results back, even if DHEA looks normal, even if testosterone looks normal, if you start noticing that you're thinning, you may actually have high DHT in the scalp only. It's activated by your scalp activity. The other thing you can look for is if you're starting to get like a lot more facial hair, right? Like we become chia pets. I had no facial hair at all. And then I went through menopause and now I'm fuzzy. So if you start noticing, more chin hair, those kind of things, that can also be a sign that you've got DHT activity. If all those things come back and your blood levels look normal for androgens, testosterone, DHEA, and DHT, but you're pretty sure you have some hair loss going on and it's hormone related, the first thing I would think about is start using products like shampoos and other topical products that block DHT, right? Saw palmetto is a supplemental herb that does that, improving zinc, even Nutrafol. Nutrafol's maturity product is one of the things that they have in there is a combination of herbs that help block a little bit of DHT. However, when you have it on the surface, that's going to block it there. Medically, this is where you need a really, really well-versed menopause trained specialist that's not just going to look at blood levels and ignore what is really going on. And so, because they should be able to adjust your hormones and get your testosterone level up look at your estrogen, progesterone, particularly if they are off balance, and balance them, and also block DHT. So for instance, for me, I used topical things, but I was still having issues. So I use a very low dose. This is not, I mean, obviously I'm a PhD, not an MD. I don't prescribe, but I use a very low dose of a blood pressure medication called spironolactone. And what it does is it blocks the production of DHT. So I don't get that overbearing production of it, and that will reduce the activity in the scalp and in the scalp. It doesn't lower my blood pressure because it's a very low dose. And as a drug, it's not really used that way. It's usually stacked. But for a lot of women, that doesn't get done. And they start losing their hair, and their doctor's like, oh, that's just what happens.
Oh, wow. And how does it affect our scalp health? Like
Yeah.
a lot of
So,
people report that they've got itchy, dryness.
yes. Yes. So we have to remember that when we start losing these hormones, estrogen and appropriate levels of testosterone and progesterone, our skin gets dry, right? So all of a sudden you notice that it gets dry, it gets flaky. Well, it's definitely on the scalp, so you get itchy skin. And that's because our sebaceous glands, our oil glands, are related to our hormones, and they're influenced by our hormones. Like if you have way too much androgens, you'll get too much oil gland production, and that's why we often get acne. But as all of those start to decline, everything dries out. So that's why we get more wrinkly. That's why our skin gets really dry. And then that's going to make your hair dry and also be a sign that hormonal things are occurring.
Okay, got it. And so why does our skin become thinner and drier during menopause and menopause?
Yeah, so a couple things happen. So in menopause, the loss of estrogen basically makes our collagen production. So our body produces most of its collagen. So even if you weren't taking supplements or eating collagen, our body can produce collagen internally. It drops by an average of 30%. So that includes the collagen in your skin, your nails, your hair, your collagen in and around your joints, which make up kind of the lubricating part and sort of think of it as the brake pads for your joints between each other. Um, and you're in between your different parts of your body. So we see this extraordinary change in collagen levels. And as that occurs, we also see a thinning of the skin and a loss of the superficial fat pad. So I'm going to hold my hand up. Sorry, I remember in my car, but you can see the veins of my hand. 15 years ago, you couldn't see the veins in my hand. I had kind of puffy fat pad underneath. And it's not that I became more bony or more muscular or more vascular, right? It's that we're losing that sort of fat pad. Well, the same thing that happens to my hands start to happen to our face. So we start to notice that our cheeks become a little more saggy. We lose volume underneath the eyes because we don't have as much cheek volume. And so we see deepening of the eye circles around the eyes, and even like your nail growth can change. What's interesting about collagen supplementation actually has probably the best. Its research isn't that great when you look at disease states and other things, but it is very strong, I would say, on like the skin, hair, and nails. Where supplemental collagen can help because it helps provide the raw material that your body can turn around and dismantle and then make back into collagen.
Okay, got it. And what causes the increased facial hair growth?
It's mostly the loss of estrogen. So your estrogen is your main kind of feminizing hormone, and the relative excess of androgens, DHT, testosterone, and DHEA relative to the estrogen. Because again, you could still be low on testosterone, but you're going to get more hair growth from it. Just because your estrogen levels in menopause are lower than a man at the same age. So a 6-year-old man has more estrogen than a menopausal woman.
Wow, that's
Yeah.
crazy. And why would our skin become more sensitive and like why do we need to be really thoughtful about the products that we put on our skin?
Yeah, the other part too is our immune system is regulated by estrogen, right? So estrogen has this, and progesterone to some degree too, testosterone, but estrogen's a bigger player. And so it modulates immune cells like mast cells and some of your inflammatory cytokines. And so when we lose those hormones, what often happens is the control mechanism for like histamines and your mast cells, which go fight things and dump histamines, and even your regulation of your immune system between allergies and not sort of take a sideways step. And so for women, all of a sudden we might notice, I get more rashy, I get more itchy, I get, maybe things like rosacea on my cheeks. I might start getting more allergies, like seasonal allergies or topical allergies. And it's because we've lost that sort of control mechanism of the immune system, during our perimenopausal journey.
Okay, got it. And hyperpigmentation. We see a lot of women that are complaining about that. Like how is that informed by perimenopause and menopause?
Yeah, so this is really common in a couple different instances. So in some women, if we have kind of excess estrogen relative to progesterone inherited, right? Inherited, meaning because everybody's a little bit different. So we can't come out and say every 25-year-old woman should have this level of hormones. It's all a little bit unique. But if you have excess estrogen, what happens is we get a darkening of the skin called melasma, especially in exposure to sun. And so you get these kind of dark brown patches that'll show up, particularly on the face, but it can show up elsewhere. So that often happens genetically, and we'll see it in somebody much younger. Now, we can do things to balance the hormones and sort of stop that from happening. But the other time it happens is in perimenopause. In perimenopause, because progesterone declines much earlier than estrogen, what you end up with is often a period of time where you're in an estrogen dominant state, meaning that your progesterone is too low relative to estrogen, and therefore you get more of this sort of darkening of the skin and these sort of patches. It's called melasma again. And often, if you get the hormones balanced, that starts to balance back out.
Okay, great. And how does like menopause affect wound healing? I know I've heard women complain about things taking longer to heal.
Yeah, it kind of goes back to that. Why do we get sort of itchy skin or rashes and things like that? Because estrogen is immune modulating and kind of immune controlling. The ability to recover from injury, reduce inflammation, or have targeted inflammation that then turns off can be dysregulated. So we get more like scarring, like, we injure ourselves and it's like, okay, that scab stays longer and then it doesn't recover as well. Um, and then depending what else is happening with the immune system, our cortisol levels and the other hormones, we may see sort of an exacerbation of that as well.
Okay. Got it. And so, what product do we have at Metabolic Blueprint that helps with some of these skin changes? And I just popped it in the chat.
Yeah, we really.
We really just lost her. How are you, sweetie? We'll cut this part
Hi.
out.
Well, thank you.
Hi.
Great to see you and beyond. So fun.
Yes.
Yeah, I'm in Miami. So
Oh,
now I'm 2
awesome.
weeks in and I've been wanting to join. So it's just so awesome. I
Awesome.
joined a women's midlife walking group here called
Awesome.
which you may know of, but the founder started this walking group, and now these walks, these like strength building walks, are in LA and New York, but it started in Miami. So I've been
That's
thinking about you
awesome.
here.
Yeah,
You're
we'll have
pushing.
to connect. I'll have to hop on
That'd be
a
awesome.
train at some point and head over. So
Is she back? I think she's back.
she's
Okay.
back. All right, we'll chop this recording and take this piece out. You're on mute. Okay. All right, let me ask that one again. What product
Sorry,
do we
technology.
have at Metabolic Blueprint that helps with some of these skin changes?
Yeah, so one of my favorite products that we have created is a product called By Est Mastery. It also goes by Face Mastery if you look at it. And what it is a topical estriol and estradiol cream. And it's in this beautiful shea butter, jojoba oil, aloe combination. And and essentially what it does is in a topical way, it adds estrogen to the skin surface. And so when you apply something locally, whether it's vaginal estrogen or facial estrogen, what it does is restore the suppleness, the collagen production, the moisture, and everything, and reduces wrinkles in that space. And so Biest is designed to be used topically, cosmetically. And what I have people do is just do like a little half pump. All you gotta do is like a little half pump, and put it in, you can put it in your other serum or your other cream, mix it together and put it on once a day. You don't really need a lot. And here's the thing, you can also use it in your nether regions, right? So whatever's good for the skin here is great for the skin down there, because we know localized estrogen helps protect the vagina, vulva, and other tissues. And as a matter of fact, a study came out last week showing that topical estrogen also reduced the risk of colon cancer in
Oh my
women.
goodness. That's incredible. I was actually just going to switch over to some vaginal and pelvic changes as well. So, what's causing the vaginal dryness and tissue thinning that so many women report?
Yeah, so probably this is your canary in the cage, right? Is our vaginal tissue. And we have mucus producing cells in the vaginal area that are estrogen sensitive, right? And so when we start to lose our estrogen levels, they dry out and the tissue thins, right? So it's not just the skin's, like the interior sort of membrane of the vagina, but even the material around it. So like our vulvar lips, right? That kind of puffy part outside. And the interior labia, which is the tissues inside, will start to regress because of the loss of estrogen. So what happens is we can get vaginal dryness, vaginal pain, risk for UTIs and also yeast infections, because that changes the microbiome. But it also makes sex very, very painful. And some women, that pain can be so bad that even like walking, exercising can become bad. And we see an increase of things like vulvodynia also, which is kind of burning, painful, areas on the vulva. And that's all related to a decline in estrogen.
Okay, got it. Well, no, that's so many people, it's definitely they're seeing changes, so that's great to know. And then how early can vaginal atrophy start beginning?
It can begin long before your periods come to an end.
Okay.
I think one of the things, and this was a fallacy, I even sort of, I don't know if I embraced it, but it didn't occur to me because we've never really studied um, how early does a woman start to experience real significant estrogen decline before their period stops. So essentially, what we still need to find out in research is, how early does that decline happen? Is it 3 years before the period ends? Is it 5 years? Because we know like there's an acceleration of bone loss and everything else. So when it gets to the vaginal tissue, what is probably true is you probably need support long before your period stops, right? And especially if you start experiencing symptoms, UTIs, yeast infections, painful sex, dryness, vulva pain, all of those things are classic signs that you're experiencing it regardless of your periods.
And why are the UTIs becoming more common at this phase in our life?
A lot of it boils down to the microbiome changes in the vaginal, urinary, and tract area. So we have bacteria that belong in there. And when we lose estrogen, what happens is the pH of that area changes. And so a lot of your good bacteria, like your lactobacillus and bifido, start to die out and other bacteria grow. And that increases our risk for infection and both yeast infections and vaginal infections.
Okay.
We have studies that go all the way back to the late 80s showing that just having vaginal estrogen reduces our risk of UTI, which is the most common infectious cause of women's death, by literally 87%. Like every woman in a nursing home, all the way down to menopause, should be on vaginal estrogen.
Wow, that's incredible. And so what product do we typically prescribe for that?
We can definitely use prescription strength. So we use vaginal estrogen prescriptively. We can also use, because we use oils, those same oils can be used in that area as well. And then a lot of people use the Bias Mastery and just use a little bit both places, if they're using
Okay.
the Bias Mastery on the skin. But our prescriptive oils also work if you use them in a carrier as well.
All right. So, final physical change. Why are we experiencing joint aches during perimenopause and menopause?
Yeah, so this is called the musculoskeletal syndrome of menopause. So we just did the urinogenital syndrome of menopause. So this is the musculoskeletal. So we talked a little bit already about the changes in lubrication, collagen production, right? And so what we see when we see the muscle pain, joint pain, and aches that we see during menopause is because we lose estrogen in particular and we don't have as much testosterone. What we also see is the sacs that are around your joints, right? So each joint has collagen produced sort of brake pads between the joints, right? So between the knee bones, you have brake pads. And that brake pad is made out of a combination of collagen and other materials, but predominantly collagen and cartilage. Well, when we can't make those things anymore at the right rate, we also see degradation. And then the sac that's around it, so every single joint has a sac called a bursa, and that bursa sac also dries out. The things that help us make lubrication for our vaginal tissue also lubricate our joints. So we often see more inflammatory joint pain. The other thing that happens is tendons and ligaments. So one of the more common things is we see a thing called tendinopathy. So that means a drying out and an inflammation of the tendons, right? So one of the most classic places you'll see this is along your hips. So if you were to run your hand from like the side of your hip down to your knee and push a little bit, 9 times out of 10, women will say, that's a little tender, right? That's your hip tendons, right? That's your IT band. That gets dry and flaked. So think of it as sort of like fraying rope. And when it starts to do that, it dries out and then it becomes inflamed. And so we get inflammatory activity. Like it's real common for a woman to go, I used to be able to sleep on my side and now it hurts. So I keep flipping side to side to side. And this is all because of loss of estrogen. Those same things will increase your risk in joint related injury, torn ligaments, torn tendons, um, you know, bursa changes where you get inflammatory activity and you get kind of an inflamed bursa, so you might get an inflamed knee. This is very specific to women because of the loss of estrogen.
Okay, perfect. Well, we've covered a lot today. Hair, skin, vaginal dryness, joint pain, whatnot. So what would you recommend for anyone that's experiencing any of these things today? Like, what is the best way to get blood work and be able to really assess where you are?
Yeah, I would say, especially if you're perimenopausal, you don't need to wait until your period stop to address these things. It's better to address them as they're occurring than wait until everything's sort of on fire. And so I would say the first thing is if you have a practitioner that you've been working with, it might be the person that delivered your babies that hasn't talked to you about these symptoms, they're probably not your provider. Less than a third of OB-GYN programs right now even have any training in menopause. They were designed and trained and they are surgeons. So their job is to help deliver babies. It's not to talk to women about their hormones. They just became the de facto women's health expert despite the fact they're not trained. So it's important to have somebody that can be your partner here that really understands the full effect of menopause. So I would say first, kind of assess your care provider. Obviously we have care providers that are certified by the Institute of Bioidentical Medicine that understand the depth of impact of change in hormones. I'd say the other thing is if you're not in menopause, right? And you're kind of in between, this is a good time to get your sex hormones along with your thyroid hormones tested. Because the reality is you could have something going on here and you may not know it because it can change over time. And just the sex hormones alone may not show all of the same pictures. There's significant correlation between thyroid malfunction and perimenopause, particularly if you have musculoskeletal issues, like hip issues. There's a relationship between hip tendinopathies and thyroid issues. So you need labs. It's a good time to get labs and get the knowledge.
That's amazing. Well, thank you so much for everything you shared today, Dr. Betty, and definitely share this with your friends if it's something that you want them to listen to. We've got some exciting announcements coming up on Menrva Lounge over the next couple weeks. Thanks for joining today. Make sure you catch us on the next one.
Thank you, everybody.